un placer para mí presentaros al doctor Stefan Toggweiler, está por aquí, ya, que nos va a hablar sobre la experiencia con válvula aórtica Accurate Neo de Symetis. El doctor Stefan Toggweiler es el jefe de hemodinámica del Hospital de Lucerna, en Suiza, y la persona que más experiencia tiene en Europa con esta válvula y por tanto la persona adecuada para contarnos su experiencia. Stefan.
Thank you very much for this kind introduction. It's a real pleasure and honor to be here in Spain. This is the country where I spent my summer holidays during the last 5 years, and I'm here as a speaker, so it's a real privilege. So let me show you the Symetis Accurate Neo valve. These are my disclosures. I'm a proctor for Symetis. The valve is a self-expanding valve. It has a supraannular porcine pericardium, and it's about 5 centimeters high. You can see at the top we have the stabilization arches. In the middle we have the upper crown, which is gonna, once you have implanted the valve, the upper crown is gonna sit just above the native calcified leaflets, and then at the bottom we have the lower crown with minimal protrusion into the alveoli. Now the valve can be delivered via transfemoral or also transapical access. If you look at the valve, at the bottom part of the valve, you can see that it has an X shape, sort of an X shape, and it's very similar to the native anatomy where you have the narrower annulus and the wider sinus and alveoli. So we're actually going to put the narrowest part of our valve into the narrowest part of the native anatomy. The valve is available in 3 sizes. You can see them here, small, medium, large, and they all go through 18 French sheath. So the vascular complications will be quite low. Let's look at the proximal end of the delivery system. We see that we have 2 knobs, and we're actually going to release this valve top down, which is, I would say, unique for a transfemoral valve. So first, you're going to turn knob 1, and you're going to flare the upper part of the valve. Once you're happy with the position, if it's still in the correct place, you're going to turn knob 2 and fully release the valve. Now this sequence ensures that the valve is going to remain completely stable during the implantation process. You will see that in a few seconds. So let's look at some patients we have treated in Lucerne with Accurate Neo. So the first example I would like to show you is a patient with heavy calcification of the valve and also extending into the alveoli, as you can see here. The patient has also an occluded LAD with calcified apex, and the annulus is quite eccentric, 28 by 21 millimeters. So in this situation, I think maybe implantation of a balloon expandable valve has at least, let's say, some risk of annular rupture. So we decided to implant a Symetis Accurate Neo. Here you can see the occluded LAD, and the other coronaries were patent. And you can appreciate on fluoroscopy the calcification extending into the alveoli. On the right side, you see pre-dilatation, which is quite important with this valve, 23 millimeter Symet balloon. And then positioning of the valve, very important step, because usually after initial positioning, if you do that carefully, without residual tension in the system, the valve will remain exactly in the same position. On the right side, you see step 1 was now performed, so the valve is flared, the upper part is open, and then we're going to fully release the valve with step 2. So let's look at another example. This was a 76-year-old woman with severe kidney dysfunction, and we really didn't want to inject too much contrast. And you can see that we did some injection with a few milliliters to position, and then on the right side you can see the live deployment and one fluoroscopy. So this is step 1 now. You can see it. We're still happy. The valve didn't move. We're pulling the pigtail and then releasing the valve within 10 seconds. So you don't have to do that, but it's possible to do it, as you can see, with 14 milliliters of contrast dye. And we used echo, of course, to check if the valve is sealing, and it was a good result. So during last PCR, Helge Möllmann has presented the SAVI TF1000 registry data, which is 1,000 patients, 30-day outcomes. And you can see the main findings here. The residual gradient was quite low with 8 millimeters of mercury. There were about 4% of patients with more than grade 1 leak. And the 30-day pacer rate in this very large solid registry was 8.2%, which I think, considering that it is a self-expanding valve, is quite remarkable. Stroke and mortality rates were less than 2%. In Lucerne, we have now implanted 82 valves during the last year, and you can see the data here of all implants that have been performed in Lucerne. So 83 was the age, and you can see that we had 2 pacemakers in 82 patients, so that's 2.4%, and only 6 patients actually had a pacemaker at baseline. Now you may say, yeah, of course it's selected patients, but it's actually not, because we had such good result. We started using the Symetis Accurate Neo as our first choice. So here you can see the number of valves we have implanted so far. I think it's 101 valves, and 2/3 were Accurate Neo. So because the pacer rate and also the rate of new conduction disorders is so low, we thought maybe we can do TAVI without putting in a provisional pacemaker, without getting venous access at all. And I don't know if some of you have used the TrueFlow balloon, but it has an inner lumen preserving some flow during inflation. And I show you a case here. So pre-dilatation with a TrueFlow balloon, there is no provisional pacemaker, not even a venous line, and then implantation of the Accurate Neo valve, of course, without rapid pacing. Now, I think we have done about 15 such patients now. I think you should not do it in patients who already have a right bundle branch block. And post-dilatation, we tried it once. It's quite difficult. So for post-dilatation, in case it's needed, it's safe to put in venous access and do rapid pacing for post-dilatation. So you have seen that we have, that the Symetis Accurate Neo has become our first choice valve, but I think there is still some anatomies where the valve is really excellent. So patients with a horizontal aorta, the valve will be on the outer curvature, the catheter, and it will position very nicely in patients with a horizontal aorta. Also, pre-existing conduction disorders, because of the low rate, the rate of left bundle is about 10% in our experience. So low, even if you have a right bundle, you will still get away in most cases without a pacemaker. Also patients with chronic kidney disease, because you don't need much contrast dye. Calcification extending into the LVOT, we have seen this example. I think it's very safe there, and also low coronary ostia, because the upper crown will deflect the native calcified leaflets and prevent obstruction of the coronaries. Now there is some patients where I would not use the Accurate Neo. For example, if you have a very eccentric, very calcified annulus, let's say 23 by 30, I think the sealing will not be very good. We learned that in our last cases. Also, if you have a big chunk of calcification, of course, that's not ideal for any valve, but I think if you have an otherwise large sinus, if you have enough space, I would use a Sapien 3 in this anatomy. So in summary, I hope I was able to show you some of the unique features of the Accurate Neo valve. It's a supraannular valve, so you have seen the gradients are very low, between 6 and 8 millimeters of mercury. The frame shape is similar to the native anatomy, so we're going to implant the narrowest part of the THV into the narrowest part of the native anatomy. We have seen that the valve is very stable during top-down release. It's very easy to use. It's also quite nice for center who don't do like 100 TAVIs each year. And you need a low amount of contrast for this valve. And the time during which the valve is actually across the aortic stenosis without expansion is very short. Also, the valve has a nice balance of radial strength, so it will be a bit more at the level of the calcified leaflet and the annulus, whereas in the inflow portion of the LVOT, the radial strength is very low. And I think with the good selection of the balloon for pre and post dilatation, you can achieve a very low pacer rate. I've shown you 2.4%, and that compares very well, of course, to the other TAVI devices, but it also compares very well to open heart surgery. If you look at the recent trials and registries where TAVI candidates were treated with open heart surgery, the pacer rate is usually around 5%. So I think this valve may have the potential to lead to a paradigm shift that TAVI is not necessarily associated with higher pacer rate than open heart surgery. Thank you very much.
Thank you, Dr. Toggweiler. I'm sorry, but in this session we do not have any questions.